Hello, everybody out there in the Western Virginia EMS region. This is the protocol Rollout. My name is Dr. Eric Stanley, and I am joined by
Dr. Allison LaPera
and Dr. Brian Eakey.
It's good to have you all here. We're excited to finally get these protocols out to you. We know they've been a long time coming, and we thank everybody for their patience.
So there are going to be some things that we cover that apply to everybody, and then a few ALS-specific things a little bit later on that we'll discuss.
Yeah, but I think in general, all of the information in this rollout is going to be helpful for all providers, even if little parts of it don't apply to you.
The first thing that we'll review is some specific changes in a few of the protocols. Second, we'll go over the new pediatric standard HandTevy. Third, we'll cover some of the new state scope red dot skills. And finally, finish up with a little intro to the critical care section.
All right, so there were no major changes to the breathing protocol, no changes to the algorithm, but you will notice that there is a change in terms of titrating PEEP. We had been starting at 7.5, and this is still where you may start, but you can titrate this up or down depending on the patient's response. Beware, as you titrate PEEP up, there is increased potential for hypotension, so pay attention to your patient. And this does represent one of the red dot skills, and we'll cover this concept a little bit later.
Next is the hypertension protocol. No major algorithm changes. If you'll notice in the small text, there's some new text about underlying causes to consider for hypertension. And for the paramedics who can check out critical care, there's a new malignant hypertension protocol.
Next up is the pain protocol. There are no major changes to the algorithm, however, we do want to emphasize the use of PO pain medications. And this comes from a paper that was recently published in Pre-Hospital Emergency Care by Dr. George Lindbeck, our state OMD. This sets us up to provide analgesia to our patients in the field as early as possible, and it also sets us up for the emergency department to be able to provide multimodal pain therapy.
So next up is our diabetic protocol. You'll notice that the glucagon routes have been updated. Previously, we had an intranasal route for administration of glucagon. The current glucagon that we carry in the drug box is not appropriate for intranasal administration, so this route was removed. Instead, EMTs can now give glucagon intramuscularly, and that has been added in terms of that route of administration for EMTs. So for patients 5 years or older, EMTs would give the entire vial, so there's no calculation of drug dosage to this protocol.
Bleeding protocol also has no major algorithm changes, but we have updated the indications for TXA. Previously, it was only for obvious external extremity bleeding, but now we've included suspected intrathoracic or intra-abdominal bleeding.
Next is the head injury protocol. You'll notice that we specifically included to avoid hyperventilation. Otherwise, there are no major algorithm changes. And this comes from the EPIC study, the Excellence in Pre-Hospital Injury Care study, where prevention of hyperventilation is important, and hyperventilation is found to lead to worse outcomes.
Under the resuscitation procedure, we've removed emphasis on double sequential defibrillation. This was a result of the 2020 update from the AHA, where they now no longer recommend routine use of double sequential defib. We also recognize that this may actually break your monitor and certainly voids the warranty.
Let's take a minute to review the relatively complicated landscape around refusals. In accordance with a strict interpretation of the Virginia state statute, 14 to 17-year-old minors can refuse, but there are some caveats to this. They're only allowed to refuse if a responsible party is not available. And they must also demonstrate capacity, meaning they have to have a reasonable understanding of the situation and the risks that a refusal may involve. It's important to remember that a parent or guardian may overrule the refusal of a 14 to 17-year-old. To further complicate matters, there are also some special circumstances to keep in mind. Minors that are married, divorced, or emancipated can also refuse, as well as pregnant minors can direct the care of their baby during their delivery. So the next thing to discuss is the HandTevy Pediatric Emergency Standard. The state of Virginia has invested in the HandTevy system, and we have updated our regional protocols to reflect that now. One of the major differences with the HandTevy system is that age is the primary driver for how you will treat folks, and each age has its own page within the protocols now. This gives us some advantages. We can start reviewing those en route to the call with a similar efficacy as you would find with a length-based tape. The age range that you will find within the protocol set is from newborn to age 13 years old. After 13, 14 and above, you just use the standard adult protocols.
Another detail we've tried to clarify for pediatric dosing is the med math. So EMTs can still give some pediatric medications, but doing a dose calculation is not in state scope. So if you look at the first page of the PEDS reference, you'll have a specific section there that shows the EMT PEDS medicines that you're allowed to give. These are all the standard adult doses, but they apply for different age ranges. So for example, you can give an adult dose of albuterol to a child 2 years of age and older. Or we mentioned previously, you could give an intramuscular glucagon, a full adult dose, to any child 5 years of age or older. There's also specific caveats that EMTs may give EpiPens. It's the EpiPen Junior for 3 to 8 and EpiPen Regular for 9 and above. And then the final thing is over-the-counter medications. So over-the-counter Benadryl, over-the-counter ibuprofen, and over-the-counter Tylenol, EMTs are able to follow the instructions on the box. So they could not do the med math for the specific pages here in the PEDS reference, but they can follow the directions on the box for pediatrics. AEMTs and above can do the straight drug dose calculation and use the dosing that is listed here in the pediatric reference.
So in addition to switching to the HandTevy standard, HandTevy also has their own app. If your agency is interested in accessing this app and downloading this app, please contact the Western Virginia EMS at the email provided.
Another important concept is the new red dot skills. So this year, when the state released the procedures and medication formulary inside your scope, they included a few that were marked with red dots. A red dot skill or a red dot drug is something that you can still use at your level, however, requires additional training.
At the EMT level, there are 3 red dot skills to be aware of. These include BIADS, or insertion of the iGels, or the King, CPAP, specifically the titration of PEEP, and in-tidal CO2 use. None of these represent big changes for our region. In fact, we've been doing these for quite some time, but due to the changes at the state level, they are now considered red dot skills and do require some additional documentation and authorization to use them. Please review any of this with your training officer if you have any questions.
Also different in the state scope of practice, the procedure for nasogastric and orogastric tubes was elevated to the AEMT level. So you can consider placement of an orogastric tube after securing an airway, but recognize this was moved from an EMT skill to an AEMT skill.
For intermediates, the medical patient restraint has been moved to red dot. What this means is you should recognize and review the procedure for providing medical sedation and restraint to agitated or psychiatric patients. Specifically, this refers to giving Haldol. You'll notice Versed is also included in the protocol, but that's more of an anxiolytic. It really applies to giving Haldol to someone that has severe delirium or is agitated or is fighting you. Also recognize that after Haldol administration, that patient requires ALS monitoring and transport.
For paramedics, you'll notice there are multiple skills that have been moved to red dot skills. These include RSI, or sedation, needle crike, insulin administration, and point of care labs. All of these red dot skills are already found in the critical care section. This already meets standard of training and documentation because these require special training and approval for use.
Speaking of critical care, we did want to remind all interested agencies and paramedics that we do include a separate critical care section. These would be protocols that we think are above and beyond the standard paramedic level care and are available to specifically and specially trained critical care paramedics.
All right, let's first talk about intubation and RSI. There have been some changes to this in terms of the number of years of experience. This has been lowered from 3 years to 2 years as an active paramedic. The next up is malignant hypertension. This is a new protocol in the critical care section that does include low pressor as needed for signs of malignant hypertension. And lastly is the sepsis protocol. This has been changed to be in accordance with the Surviving Sepsis campaign and includes antibiotics. Please look out for your regional in-services and your extra training.
All right, congratulations. You've made it to the end.
So thanks for watching, guys. We hope you enjoyed this very brief video introduction to the protocols. If you're ready to get going with the new version, just go ahead and open up the link down below. You'll get the attestation form. Go ahead and fill that out. Sign it, turn it in to your training officer, but make sure that you are actually cleared to start using the protocols before you start using them. And then also thank you very much to everybody on the back of the book that helped us out with all of these updates, and especially for the EMS members. If you are interested in being a member of that work group committee that helps update the protocols and introduce new concepts, please email western@vaems.org. Thanks so much.